Hi guys, it's been a while since I've done one of these. This one just got me irritated, so I got permission to do a little YouTube video on this kind of sad case here. So this is a failed fusion, which is one of my coaching session patients I just recently did, actually yesterday. Got me so irritated, I decided I'd throw it up here right now. So let's check it out. So the patient is a 59-year-old female. She's a retired nurse. She is 5'7", 172 pounds, never smoked before. Was a history of DVTs back in the 90s, haven't had no reoccurrence since then. She does have a history of a multiple ACDF for cervical problems from C3 to C7. That's going to be another story. She's actually got 2 spondylolistheses above and below. So that's another problem, but let's get to this problem. So before, she's had a chronic history of low back pain and right lower extremity pain, which worsened over the last probably 10 years or so. For treatment for those problems, she's tried epidural steroid injections, which initially helped, and then they no longer helped. Interestingly, she had a sacroiliac joint block, which did help. The original diagnosis, this is all according to the patient, right? I don't have the other side of the story, so just take that for what it's worth. She originally diagnosed with a spondylolisthesis at L5-S1 and spinal stenosis with instability at L4-5. I don't have records or images to confirm those were actually the case, but that's what she said. And then a TLIF was performed in 2018, in the summer of 2018, at L4-5 and L5-S1. Sacroiliac joint fusion was not performed or was not addressed. So no wonder things didn't work out so well. I mean, if the SI joint blocks work, that means the SI joints are contributing to the pain syndrome, completely not addressed. But I'm digressing. Surgical outcome was a disaster. Patient was much worse after the surgery and has never gotten better since. Surgeon has told her on several occasions the fusion construct looks great. There's nothing is wrong with the fusion construct. There's no need for revision surgery. Sorry, your nerves are damaged. I'm sorry. Nothing we can do about it. So go to pain management and recommended a spinal cord stimulator. So she decided to consult me to get a second opinion to see if I could see anything that maybe the other docs couldn't see. So the current subjective status, she's miserable. Even she's on opioids and still miserable. She can't work. She's doing real estate now, and she's retired from nursing, which was too physical. But real estate's not that tough, and she hasn't been able to even do that. So low back pain on a numeric rating scale is 10/8. 10 is severe pain. You're headed to the emergency room. Her right buttock, thigh, leg, and foot were all rated between 8 and 7. There's the exact numbers. 30% of her complaints are low back pain, 70% are buttock and lower extremity pain. The extremity pain is the #1 problem, just making her life miserable, not sleeping great. Just a sad story. She and her husband, I talked to both of them, and she was very upset. Crude neurological testing. I actually have a YouTube video on the exact tests that she did. I can link down below. So she had slight weakness in gastrocnemius power, which is L5-S1. Extensor hallucis longest power was reduced about 4/5. 5 is normal strength, so slight weakness. She could still do these tests. And dorsiflexion, walking on her heel, she also had some weakness. Not foot drop though, 4/10. Quadricep power, so a pretty broad weakness here of the lower extremity. Current medication, she's on 10 milligrams of hydrocodone per day, 5 in the morning, 5 at night. 200 milligrams of gabapentin to help her sleep, calm down the nerve. Cymbalta 20 milligrams twice a day, also another kind of nerve quieting medication. Nevertheless, oswestry disability is still 42, and that's a miserable number. Usually means you can't work and life is not good. All right, with that said, let's get right into the CT myelogram that was recently ordered. And mind you, the surgeon said everything is fine. There's no need for a second opinion. You just need a spinal cord stimulator. All right, now I'm not going to teach you how to read an MRI or CT here. I have plenty of videos on that, so I'll put a couple links down below. So you're going to be completely lost. I'm going to assume that you know how to read these things. I mean, this is probably, the people watching this are my kind of medical radiology followers, primary healthcare providers, spine experts, and such. So here we have a sagittal view, a mid-sagittal view. Of course, we can label these. I can help you a little bit. So there's the sacrum here, S1. And there's L5, 4, 3, 2. Some of you are scratching your heads already looking at L3. I know. I'll get to that though. Now we have a cut line going through the L2 disc, right? So that's L2. And this is a CT myelogram. So the patient was injected with myelographic dye intrathecally, and that shows up on imaging as white. It wasn't the greatest myelogram in the world because it's all accumulated down here. They didn't get her into the tube fast enough. But nevertheless, we can still see an outline of the thecal sac, and we're going to be looking for fill defects. Remember, her complaint is right radicular pain and low back pain. So let's see. And remember, this is a great fusion construct. The surgeon did not ostensibly, now again, I don't have his side of the story, but ostensibly there's no other surgery was recommended and no further follow-up or second opinion was needed. And so I'll go through this. So here's a cut. Remember, this is the cut line, that orange line. So for example, I'm cutting through the L2 vertebrae here, and I'm not going to go through the parts, but you can see very big thecal sac, a little bit of a rotatory scoliosis she has. You can see the little black dots here. Those are the nerve roots. Cerebrospinal fluid would be where the contrast is supposed to be. If I drop it down, now we're at the L2 disc, and so we can see the disc right here. Do I need to? I don't need to draw this, right? You guys know this. Might be a little bump right there. I don't know if that's pedicle coming in. We'll take a look at that. There's the disc. You can't really see much of the nucleus. You can maybe hallucinate it in there a little bit. Right? Facet joints are right here, superior articular process from the bone below. So if this is L2 disc, that's the L3 superior articular process. And remember, those you can get bone spurs off those, and they can stab the canal there. And this is all L2 property. This is the vertebral arch here. Right? Facet joints, of course, are right here. Or my students know them as the Z joints. Nobody ever calls them the Z joints when you get out of school. They're always the facet joints, which isn't the greatest name in the world. Alright, so that's it. So go to my video if that's all I'm going to do. So no problem at this level. So the first thing that comes to mind is, why in the world would they not include L3 in the fusion construct? L3 is shot, right? We're bone on bone here. You can see a nice disc space here between, this is L2 again, remember? You can see a nice disc space here at L2, right? It's bulging a little bit. You can see a little bit of a fill defect here in the back. This disc is gone. So, I mean, this is grinding on top of each other. The facets are probably jammed into each other. So that's the first thing I'm like scratching my head. I don't quite understand the thinking of why that wasn't included in the fusion construct. But nevertheless, it wasn't. So I'll come back to a point here. Let's just kind of look at the general placement of these screws. So now we're in L4 vertebral body. Okay, and you can see the pedicle screws. Now, let's keep our eyes right here. So here's the pedicle. That's the target, right? The surgeon has to put the pedicle screw through the pedicle, right? It has to go right through here. Let's see where it goes. Oh, that's not good, is it? It's outside. It's breached the cortex of the bone, right? So it's outside. You see the threads outside. So he missed the target here. But the thing I'm worried about, she's got pain down that right leg. Here's the L3 nerve root, and you guys aren't used to seeing this, but the nerve root above the L3 nerve root can also be seen right where the transverse process is. So we have the L3 nerve root right here. See the problem? That screw could be irritating that L3 nerve root, right? So pain management doc, a really good doc, might be able to block it. You could also say, well, you could block it up above in the neuroforamen. And those of you see, there's the nerve root right there. See, there's the screw. It's hit. I think it's hitting it. And too bad this wasn't a thin slice CT. We could see that a little bit better. But I think it's hitting it. Now the problem is if we go up and look at L3 where it comes out of the neuroforamen. So let's go look over here. And let's go up. Because you could do a SNRB, selective nerve root block, up at L3. But we got a problem at L3. See, this is what irritates me. Now I don't know what this looked like before surgery because bone spurs can sometimes come on. But we see another problem. Here's the hole. There's L3. And I'll show you where the cut is. See, the cut is right through the right. So the L3 root would be right here. That's the one I think is compressed down below. But let's go back over here and look what happens to this bone spur. You see that sticking out? That's a bone spur. And it could be rubbing the L3 nerve root as well. In fact, in this view, this cut right here, to me, here's the nerve. And there's the bone spur. It looks like it's at least touching it, if not stabbing it. That's the same nerve root, so she's got kind of a double crush, potentially has a double crush going on. So what I recommended is a SNRB, a selective nerve root block, where they very carefully try not to poke the nerve, inject about 4 or 5 cc's of lidocaine-mericane combination, fill this up, and keep a pain diary and see what happens. If her leg pain dramatically improves by at least 70 to 80% or so, well, hey, we figured out what the problem is. You got this nerve is damaged, but there might be hope for it because we can fix the irritation by doing a foraminotomy here. And they're going to probably want to extend the fusion up. But you'll see, we'll get to the other problems. So, I mean, this certainly is worth. My recommendation was I sent her to HSS, is where I send all my complicated cases to Hospital for Special Surgeries. I have no relationship. I don't talk to them. I don't know them. But I've been doing this since 2003. I've had good luck with them. I like UCLA as well, and UCSF in my neck of the woods are my kind of go-to places where I send people. But yeah, so that could be a cause of her horrible leg pain, and that's her #1 complaint. So now let's some other surprises as we go on here. So let's go back to the center cut here. And some of you are thinking, I know there are some spine surgeons who watch this this channel, and I know some of you are thinking, what in the heck's going on here with these cages? Why are they using titanium? I don't know why they're using titanium. Everybody uses, that I know, uses peak cages, polyether ether ketone cages, which has the same Young's modulus as the bone. In other words, the peak cages are the same hardness as the bone. These titanium cages are super hard, and they can cavitate and sink in and cause trouble. So I don't know why the surgeon used those, but that's unusual. I don't usually see that in this country. Okay. So let's see what else we can see. So we got one screw, pedicle screw, messed up. Let's go look for another one messed up. All right, so let's go down to L4. And now we have another thing, a problem I don't like. So it's like, come on, what the heck? The pedicle screw is clearly went through the cortex of the bone, and it's sticking out in the wind here. Right? This one looks fine. This one is in the substance of the vertebral body where it's supposed to be. But what the heck? Come on. It's clearly out. But the thing I don't like, being an anatomy professor, I don't like this. External iliac artery. Internal iliac artery. Too darn close for my liking. Right? That screw is right up against the internal carotid or not carotid, the internal iliac artery. And these are pulsatile. So is this pulsing into the screw? I don't know. It's not sharp. The screw's not super sharp, but nevertheless, that's too close for comfort for me. I worry that over time that could start to leak and bleed. And these are powerful arteries. They have a lot of blood flow in there. So again, second opinion ASAP. All right, and we're not even done. And the patient's husband, who works in the radiology industry, actually saw this one himself. So look, as we go down, the screws are way out of the sacral base. And if we go down here, let's take a look at that right one. Oh, that one's even worse. There's the internal carotid artery again, coming right there. That is definitely contacted by that screw. So again, too close for my liking. Very similar situation. I have another YouTube video on a patient from India who had the same thing. After I did the video, they immediately pulled those screws out. So, and this one, this is not good. This makes me nervous. So, second opinion is definitely needed here to take care of that. Is the patient even fused? That's another question. Is there solid fusion? There's quite a bit of bone in here on this view. You could hallucinate maybe some lines here. But I think they're probably fused. Not a super robust fusion, so that, I mean, there's some woven bone in there. Same down here, there's woven bone. It's not a super solid fusion, but I think they're probably pretty well fused. So anyway, that is kind of short and sweet of it. The other thing that the question is, if the selective nerve root blocks knocked out, or the SI joint blocks knocked out her pain, so that means that these sacroiliac joints here, which are sclerotic here, there's some degeneration here, that could be a source of her back pain and maybe some referred leg pain as well. So the other question that arises is, if that was true, why didn't they include the SI joints in the fusion themselves? So that needs to be worked up. Hopefully HSS will get to that. Sacroiliac joint problems are incredibly rare, despite what the research says. I think maybe 6-7% of chronic back pain is responsible. Certainly not 20%. Certainly not 40%, like some of the chiropractic books say. which is ridiculous. 40% of chronic low back pain is sacroiliac joints. Ridiculous. Even the SI Bone, who is the manufacturer of this SI fusion equipment, they say it's about 20%. They don't even say it's 40%. So I don't know where that number comes from. Really old research. Anyway, I'm digressing again. So that's the case. I hope you enjoyed it, and thank you so much, patient, for letting me put this on YouTube. Of course, I have your name and everything's all protected. But great. We'll see you in the next video.